Welcome again to ETH Med YouTube channel. I'm Dr. Yusafet. I come with exit exam sample part 2. And if you like the video or if the video is helpful, please like, share to others and subscribe in order to get more videos. Question number 1. Miss Aster is 1.6 meter tall and weighs 75 kg. And what is her BMI? And how would you categorize her weight? So please pause the video and answer your question. So let's go to discussion. So WHO classification of obesity. So BMI or body mass index is calculated as weight divided by height square. So weight in kilogram and height in meter. Please, if they give you with centimeter, you should have to change to meter. So 1 meter is equal to 100 centimeters. So you should have to change to meter. So the category, WHO categorize the obesity as this. So underweight is if it is less than 18.5. Normal weight is 18.5 up to 24.9. Overweight 25 up to 29.9. Class 1 obesity. Class 2 obesity is from 35 up to 39.9, and class 3 obesity is greater than or equal to 14 kilogram per meter square, and this class 3 obesity sometimes called morbid obese. So if you calculate for your patient, that is 75 over 1.6 square. So the answer is A. Approximately it's around 28.8, and then the answer, the closest answer is A, and the category is overweight. So question number 2, baby Tariku, a 2-year-old male child brought by his parent to your OPD with complaint of loss of appetite, vomiting, everything. On physical exam, he has bilateral pitting edema and his weight for height was less than 17 percentile. Based on the above information, he is categorized as A, moderate acute malnutrition, B, severe acute malnutrition, C, global acute malnutrition, D, stunting. So what is your answer? So the answer is B, severe acute malnutrition. So this weight for height, if it is less than 17%, it is grade 3 malnutrition, or it is in the range of severe acute malnutrition, or SAM. We call this as SAM. So this is severe acute malnutrition. So let us discuss. So Waterlow classification. So weight for height, which tell us about wasting. So if it is normal, if it is greater than 90, we call normal. Mild or grade 1, if it is 81 up to 19. Moderate or grade 2 malnutrition, if it is between 17 up to 18. If it is less than 17%, we call it severe malnutrition, and it is grade 3 malnutrition. So the other way, height for age, which tell us about stunting. Height for age will tell us about stunting. If it is greater than 95, we call it normal. Mild, if it is 90 up to 95, and if it is severe stunting, it is less than 85%. So stunting, if we do height for age, not weight for height. We found stunting if we do height for age. So Waterlow classification, chronic malnutrition resulting in stunting. So by the way, if you are talking about stunting, or if you found stunting, it tell us about the chronic malnutrition. As you know, you will classify, or one of the classification of the malnutrition is acute or chronic malnutrition. Wasting will tell us about about acute malnutrition and stunting, or if you found stunting, it is chronic malnutrition. So what percent weight for height? Height for height is calculated as weight of patient over weight of normal child of the same age multiplied by 100, and percent height for age based on the Waterlow classification is equal to height of the patient uh, divided by height of normal child of the same age multiplied by 100, and it's put as percent. Question number 3, suppose a screening program is conducted in Adora village to identify stunting children. To identify stunting children. So what type of anthropometric measurement could be implemented? Weight for age, height for age, body mass index, and weight for height. So the answer, it is, which anthropometric measurement will tell about stunting? It is height for age. Weight for age will tell us about underweight. Height for age, stunting, and weight for height will tell us about wasting. Please, weight for height tell us about wasting. So this is another currently most of the health worker use this Z-score or WHO Z-score. So this is currently the famous one. In addition to Waterlow and other classification, this is the most appropriate, by the way. This is the most appropriate one, which is set by WHO, and it is called Z-score. So height for age will tell us about stunting, and this is if it is between -2 and -1, marginally stunted or mild malnutrition. If it is -3 up to -2, moderately stunted or moderately malnourished. If it is less than -3 Z-score, if the height for age is less than -3 Z-score, we call severely stunted and severely malnourished. This is for weight for age, the same Z-score, and weight for age tell us about underweight, and if it is less than -3 Z-score, we call it severely underweight and severe malnutrition. And this weight for height of the same Z-score, so if it is less than -3, we call it severely wasted, and this weight for height tell us about stunting. So this is some of the table of WHO to calculate the Z score. I mean, you will choose these charts to see the Z score of the patient. This is another one. So question number 4, Mr. Masalu, a 36 years female patient. She has been on INH, isoniazid, anti-TB treatment for the last 8 weeks. On the 6th week, she started to develop weakness and poorly coordinated work. What will be the possible cause? What is the possible cause of her symptom? A, riboflavin deficiency, B, niacin deficiency, C, pyridoxine deficiency, D, thiamine deficiency. So choose your answer, please. So the patient is taking isoniazid treatment for anti-TB. So in short, this patient have side or adverse effect of isoniazid, INH. So what is your answer? Which deficiency does this isoniazid can cause? The answer, it is pyridoxine deficiency. Another name for pyridoxine is vitamin B6. Vitamin B6. So discussion, INH-induced neuropathy. So drug-induced isoniazid can cause peripheral neuropathy in patient undergoing treatment for tuberculosis infection. Symptom of peripheral neuropathy: numbness, pain, tingling in extremity. If untreated, can cause severe symptoms like loss of balance, loss of coordination, and also muscle weakness, especially in the feet. So isoniazid cause peripheral neuropathy through interference with the metabolism of pyridoxine, which is vitamin B6. So pyridoxine is critical for CNS function as it is used for production of neurotransmitters like serotonin, GABA, glycine, and other neurotransmitters. So when pyridoxine enters the body, it is activated by certain set of enzymes. Enzymes and these isoniazid or INH compete for those enzymes and which reduce the amount of pyridoxine. So isoniazid causes pyridoxine deficiency. So how do we prevent this INH-induced neuropathy or peripheral neuropathy? By giving pyridoxine or by supplementing pyridoxine. So it is recommended to give pyridoxine to all people who are taking isoniazid and who have a risk factor to develop neuropathy, like patient with diabetes, uremia, alcoholism, malnutrition, HIV infection, pregnancy, and seizure. And also, if the patient, while taking without those risk factor, while taking isoniazid, if the patient develop peripheral sign symptom of peripheral neuropathy, you will supplement pyridoxine as well, especially around high dose, around 100 milligram daily. So question number 5. Baby Thomas is 3 years old male child who was brought by his mother from Town with a complaint of loss of appetite and on history. His mother tells you as he is breastfed only for 3 months, and from then onward she was initiated cow milk, and during physical examination you found skin lesion with characteristic of edema and flaky paint dermatitis, thinner and lighter hair. What will be your possible diagnosis? A. Iodine deficiency disorder. B. Marasmus. C. Kwashiorkor. D. Iron deficiency disorder. So, what is your answer, please? So, this patient, this kid have symptom of sign and symptom of loss of appetite on history and also vomiting. So, sorry, this patient have loss of appetite, edema, flaky paint, dermatosis, thinner and lighter hair, and something that the mother tells you this patient breastfeed only for 3 months, only for 3 months. So this kid is exposed for, I mean, it has high risk to develop malnutrition, and definitely this patient have sign and symptom of malnutrition. From those, this patient have edema. So it is it B or C or D? Anyone? It is edematous malnutrition, and this edematous malnutrition is called kwashiorkor. So this is Waterlow Wellcome classification of protein energy malnutrition using the Gomez classification. Waterlow put this for non-edematous as well as with edema patient. So if it is 60 up to 80%, and if the patient, the child have no edema, we call underweight. So if the patient have with edema, we call it kwashiorkor. And so marasmus, if it less than 60%, and with no edema. And if the patient have less than 60%, the graph, and then, and if it is with edema, we call it marasmic quash. So the difference between this marasmus and kwashiorkor is that this marasmic patient have that they have visceral protein is reserved for longer time. So and also this kwashiorkor patient irregular visceral depletion of amino acid or protein so affecting the visceral cellular function. So obviously, you know that uh, to 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 stay this oncotic pressure in the village, uh, that we need this adequate amino acids like albumin or protein like albumin. So if there is deficiency of this protein, so the oncotic pressure become decreased, the the oncotic pressure become decreased, and the hydrostatic pressure become increased. The hydrostatic pressure become increased, and there is the interstitial fluid and then edema. So thank you for watching. Please subscribe.